Okay, so I'm working right now. So if you see me like stop talking and then start like talking to someone else, it's because I'm signing them in. Anyways, um, so I'm outside, so it might be a little noisy, but whatever. So I'm just gonna go over all of the meds except insulin. So I'm gonna go back over the other two that we talked about yesterday. All right, so the biguanides, the metformin, that is the one that reduces the production of glucose by the liver, glucogenesis. That's the main thing. Metformin, biguanides, liver. Okay, so it also does the tissue sensitivity thing. It'll increase tissue sensitivity and slow carb absorption in the intestines, but mainly the liver. So for any test questions, that's what it'll be. Because metformin does affect the GI and the intestines, those are where the side effects are going to come from. So you have to monitor for your GI effects, like basically anything: nausea, vomiting, flatulence, anorexia, pain, whatever. And then I think with all these drugs, it's you're going to watch for lactic acidosis, especially people with kidney and liver issues, um, because these drugs, if you think about it, we haven't gone over lactic acidosis yet, but I think it has something to do with processing the lactic acid in the body. So if you take these drugs that are really hard on the kidneys and the liver, they're going to be busy with those, and they're not going to be able to help with the lactic acid, which will lead to lactic acidosis. Um, so because metformin is keeping the liver and the kidney busy, we also want to stop using it 24 to 48 hours before any radiographic dye is used, and 48 hours after. So the 24 to 48, the 48-48 rule with this drug, because that can also lead to lactic acidosis and kidney injury. Okay, so the next drug is the second generation sulfonylureas. So that's glipizide, glimepiride, and glyburide. So basically, if it's GL and ends in ide, it's a second gen sulfonylurea. In these drugs, the main thing is pancreas. It stimulates insulin release from the pancreas. It'll cause a decrease in blood glucose because you've got more insulin going into the blood. So any question on the exam that is talking about any of these drugs, it's probably going to be the one we talked about yesterday. Your patient, or you're teaching a patient, blah blah blah, which statement indicates proper teaching, and it's going to be like, my second gen whatever stimulates insulin release from the pancreas, which will decrease my blood glucose. Again, this drug also increases the tissue sensitivity following long-term use. So you use the drug a lot, and it's going to make the tissues more sensitive to insulin, which is, I think, good in regards to type 2 diabetes, which our oral drugs are used for. So with these drugs, all of them, you're going to be watching for hypoglycemia because they're decreasing the blood glucose, which can lead to hypoglycemia. So you want to report any symptoms of that. And with any of the drugs also, avoid alcohol because it can lead to bad stuff like lactic acidosis. The second gen drug in particular, it says to give 30 minutes prior to meals. So again, our biguanide, liver, it does other stuff. It has GI effects, and you don't want to be taking it 24 to 48 hours before radiography or 48 hours after. The second gens, they are working on the pancreas for the most part, They also do the insulin tissue sensitivity. But with these, you want to give it 30 minutes before and monitor for hypoglycemia and basically all the other stuff. Important note is beta blockers, and this isn't, I don't think this just applies to the second gen. This is just in general, I'm pretty sure. The beta blockers can mask the use or the symptoms in hypoglycemia. So remember, with hypoglycemia, the person is going to be acting drunk, they're angry, they're shaky, and they have tachycardia. But if they're taking a beta blocker, it's going to mask the tachycardia. So that's an important note. Okay. Next drug is the, right here, meglitinides. So this is repaglinide and natglinide. Let's look at the names of these drugs real quick. So I don't think IDE is the best thing to go for when you're trying to identify a drug, because our second gens also end in IDE, but our second gens start with GLIP or GLI and end in IDE. These just end in IDE. And if I look at the rest of the drugs, I think that's the only ones. Yep, those are the only ones that end in IDE. So if it's just IDE, it's a metligonide. Okay, so this also works on the pancreas. It's given for the post-meal hypoglycemia or hyperglycemia, sorry. And again, you're going to monitor for hypoglycemia. Take within 30 minutes of the meal, and do not take this drug if the meal is skipped. That is like a general rule. Don't take an oral anti-diabetic if the person is planning on skipping the meal. And then again, another tip that we talked about yesterday: don't give your drug until you have the meal, not when you order it, because the nutrition people might screw up the order, or they might trip and spill it everywhere and they got to get a new one. And if you've already given your insulin or your anti-diabetic, that blood sugar is going to tank and you can create a hypoglycemic crisis. Okay, so this one doesn't have anything special about it. It's just a meglinide. It works on the pancreas just like the second gens. They end in IDE. Okay, next one. This is thiazolidinidios. I'll just call them, I don't know. That's a big ass name. And we only get one drug for this. It's enzenzone, pioglitazone. So, pioglitazone, it'll reduce the production of glucose by the liver. So this one is acting on the liver mainly, but it also does the tissue sensitivity. So far, all of these drugs have created tissue sensitivity, I think. The only one that hasn't mentioned it is the meglinide, previous drug. So honestly, all these things are kind of doing the same thing. I know that metformin is the most commonly used. So if that's a question, metformin is probably the one. A lot of these are not used anymore or barely used. But again, they all kind of do the same shit. So with this drug in particular, you're monitoring for fluid retention, especially in your heart failure patients. We already know that with heart failure, especially right side heart failure, you're going to have that edema, fluid retention. So you give this drug, it's going to increase that risk. Honestly, this applies to everything, but with this drug, I guess it's saying to monitor triglycerides, just all the labs, hepatotoxicity, and then because we are looking for fluid retention, you need to report rapid weight gain, because that can be a sign of fluid retention. Look for shortness of breath, decreased exercise tolerance. Again, the fluid is going to build up. It can get in the lungs, shortness of breath, and they're not going to be able to exercise as much. Jaundice, which is because of the liver toxicity, the yellow skin, and dark urine, which is happening because He got you?
Huh?
Did he sign you out?
Oh no, I'm coming right back.
Okay, cool. Okay, so, and then the dark urine, that's because you are retaining all this fluid and you're not sending it out. So you're going to have very concentrated urine. So when you think of thiazonolidines or whatever they are, pioglitazone, it's acting on the liver. It can really screw with the liver. It's very toxic. And it can lead to edema and heart failure in patients. So there's that. Let's see. So the next drug is the alpha glucosidase inhibitors, which is acarbose and migadol. I think these are pretty common. I've seen these in the hospital. So these are going to slow carbohydrate absorption in the intestines, and it will obviously reduce post-meal hyperglycemia. So if you think about it, the alpha glucosidase inhibitors, think about it. Alpha is not important. The glucosidase inhibitors. So think in your head, it is inhibiting glucose in a way in the GI. So it's slowing because carbohydrates are 100% turned into glucose. It is slowing that absorption. It is inhibiting that absorption. So it takes longer. So instead of your post-meal spike in sugar, it's going to be slowed down. It's going to be more of an arc. So that's what that drug does. You want to monitor liver function every 3 months and treat any hypoglycemia with glucose and not table sugar. It's like they include like basic tips on each drug. It's really stupid. That applies to everything. Take this med with the first bite of each meal. You got a green pass?
Yeah.
All right, Richard. All right, you're good. Sorry. Okay, so yeah, take this med with the first bite of each meal, and apparently GI discomfort is common. So to remember your alpha glucosidase inhibitor, your acarbose and your migadol, we're inhibiting glucose, slowing down carb absorption in the intestines, and because you're doing that, you might have some GI discomfort because your intestines are like, yo, why is everything so slow? Why are these carbs taking so long? All right, it's a little windy, so hopefully the mic isn't getting destroyed. I think there is only 2 or 3 more drugs. Okay. All right, so this one, dipytidol peptidase 4, DPP4 inhibitor. There's a bunch of these. They all end in leptin. So yeah, leptin. Ends in leptin. It's dealing with dipeptidyl peptidase inhibitors. Okay, so these will augment the natural occurring intestines of incretin. I forgot what that does. It's something in the intestines, and it also promotes. Okay, so it messes with incretin, which promotes the release of insulin, and decreases secretion of glucagon. So DPP4s, they inhibit this thing, which stops incretin hormones. This promotes insulin release, and it stops glucagon. So glucagon increases the glucose. So we want to slow that down. You want to decrease high blood sugar. So you release insulin, you let the sugar into the lungs, or not the lungs, the cells, and then you want to inhibit glucagon because you don't need all that extra sugar. This can lower fasting and postprandial glucose levels, obviously. You take the drug, it's supposed to decrease the glucose. There are few adverse effects, but upper respiratory meds. Okay, so I guess you want to be using respiratory meds because you might have some nasal or throat inflammation with it, and pancreatitis can occur. So this is kind of a weird one. I hope I don't see it on the exam because this is going to be like the one that I don't study, I think. DPP4 augments incretin hormone, increases insulin, decreases glucagon, and apparently that can hurt the pancreas and do respiratory stuff. Some more signs and symptoms. You want to report any persistent upper respiratory manifestations. So if you keep having upper respiratory issues, report it. And if you're having severe abdominal pain, report it because that's probably the pancreatitis. This drug only works when the blood glucose is rising. So whatever that means. Okay, next is sodium glucose co-transporter 2 inhibitor. And these end in ozin. Alright. It'll block the reabsorption of glucose by the kidneys, thus increasing urinary glucose excretion so that the glucose is excreted in the urine. Okay, that's pretty simple. Sodium glucose co-transporter 2 inhibitor. It's a long ass name. Very simple what it does. The kidneys, instead of getting the blood, because you got blood going to the kidneys, instead of them reusing glucose and sending it back, it is just going to send it out in the urine. So, let's see, how can we remember that? Sodium glucose co-transporter. Okay, so sodium, right? Water and sodium go hand in hand. And in this case, they're gonna have like a party at the kidneys because there's so much water and sodium, and they're gonna co-transport some glucose. They're like, yo, glucose, you gotta come with us. We're gonna go out, and then they go out in your piss, right? So I don't know. I think that's a good way to remember it because it's sending out, your urine has sodium and it has water, and now it's gonna have glucose. So it's like a party. Alright, so whenever there's more glucose in the urine, watch for UTIs, yeast infections. Simply because, like, imagine it like food, like moldy food. These little cells and bacteria, they want that glucose. So if there's a lot of glucose in the urine, your tubes are gonna have a lot of food for infections and bacteria, which means that you should report any genital burning, itching, or drainage. Now, we also have to worry about postural hypertension or hypotension in older clients. Why? I don't know. Maybe when they move. That doesn't make sense. Just co-transporter. It's in the name. Just transport slowly. Think about that. And then with this, you take before the first meal of the day. Alright. Non-insulin injectable medications. Let's see. So, non-insulin injectable meds. So this is, looks like the only no, there's two. So instead of oral antidiabetics for the type 2s, they also have 2 injectables. Because they want to be like the type 1s. They're like, dude, I want to inject some drugs. So they got these. Alright, so we've got, I'm trying to highlight it all so I can focus on it. Incretin mimetic. Okay, so both of these, I remember these. Mimetic means to mimic, right? So it's gonna act like something. So, incretin mimetic is mimicking incretin. And we've got exenatide and liraglutide, mimicking incretin, which is a hormone that is secreted, which decreases glucagon secretion, and it promotes insulin release in gastric emptying. So we already talked about that before with our, what was it, this one? Yes, so with DPP4, it augments incretin. So that's what this is doing too. It is mimicking incretin. And we remember that incretin decreases glucagon, increases insulin. So that's what we remember with this. It also decreases insulin demand by reducing fasting and postprandial hyperglycemia. That's with all the drugs, because it's helping with insulin. So it decreases insulin demand. You give this subcutaneously 60 minutes before a meal and watch for GI issues. So both of the meds that we're talking about that work around incretin, you want to watch for GI because, again, that's where incretin works. So when you mess with it, you might get some pain or flatulence or something like that. Do not give this post-meal. Oral meds should never be taken 1 hour within 1 hour of oral exenatide or 2 hours after the injection. Okay, so don't take any oral drugs with near your incretin injection. They probably interact or something, or it can lead to hypoglycemia, is my guess. So it says it decreases effectiveness. So with this drug, you're going to use caution with oral contraceptives, antibiotics, and it can decrease appetite and weight loss, report abdominal pain as possible. Pancreatitis. So I think the DPP4 also had pancreatitis. Yep, it did. So these are similar because we're both dealing with incretin. So connect these two in your head. Except incretin is usually injected, even though it says it can be given orally. Let's see, what else is there? Oral contraceptive issue. I wonder if the DPP4 also has issues with oral contraceptives. Decreased appetite and possible pancreatitis. Maybe the appetite is because you're slowing down that carb absorption. All right, last one. Amylin mimetic. So we are now mimicking amylin. So the drug is pramlintide. So amylin is a hormone found in B cells, which suppresses glucagon, and it controls the postprandial blood glucose. So it's pretty obvious. All these drugs are trying to control some sort of glucose, usually postprandial glucose, because we're taking them before meals. So don't think about that too much. But amylin found in B cells, amylin A, B cells B, suppresses glucagon secretion. And then I'm trying to remember the B cell function. So B cells, what do the B cells do again? They do fat metabolism. Okay. I can't think of anything to connect. Reduce pre-meal doses of rapid and short insulin by 50% to prevent hypoglycemia. Give sub-Q before meals. Do not give if they were hypoglycemic or have poor adherence. Give injection at least 2 inches from any insulin site. Okay. So it seems like all these drugs are given before meals except one of them, which is which one is given after meals? I don't know. I can't find it. But let's remember that our non-insulin injectables, the incretin mimetic and the amylin mimetic, they mess with other drugs. So with your incretin one, it can mess with other drugs like the orals. You don't want to give those 1 hour or 2 hour for an injection within that. And then with your amylin, you want to watch for what was it? Okay, wait. I think this one does. Oh, this one can mess with insulin. So remember that. Incretin will mess with oral drugs like. God, my brain is melting. The oral antidiabetics and the oral contraceptives and antibiotics. And then amylin messes with insulin. So you decrease insulin by 50%, the rapid and short acting, by 50% to prevent that hypoglycemia. Okay. Anything else important in these notes? Obviously, we're going to monitor literally everything. I don't think there's anything else that pertains to drugs. Okay, so with drugs, if they are going NPO on clear or liquid diet, you need to adjust their anti-diabetic therapy, especially if they're receiving enteral or perienteral nutrition. So they need those calories, so you need to adjust what drugs you're giving, because if you have a decrease in calories and decrease in glucose, you got to deal with that. Type 1 people, they need continued insulin while NPO to prevent diabetic ketoacidosis. You're always monitoring that blood glucose. Short-acting insulin is often given at a time of clear liquid and enteral food. Yeah, so liquid foods, right? You're going to give your short-acting insulin because liquid foods are absorbed quicker and easier. It creates a spike, and you want to take faster-acting insulin for that. What else? Clients under special diet need blood glucose monitoring, obviously. Whatever. So I think that's it for drugs. I'll make some other video if there's other stuff that's important.